welcome to this liver seminars from Hospital Gregorio Marañón. We have the pleasure today to have the first speaker, which is Salvatore Piano, which is Associate Professor of Medicine and Consultant Hepatologist at University and Hospital of Padova in Italy. His main research is in pathophysiology and treatment of complications of cirrhosis. His research has been supported by European grants, Ministry of Health in Italy, and ESEL. He's also recipient of the ESEL Emerging Leader Award and the UAG Rising Star Award. He's also associate editor of Journal Hepatology Reports and liver transplantation and clinical and molecular hepatology, and he belongs to the editorial board of Journal Hepatology. So welcome to these liver seminars, and we are expecting to you about the conference of acute kidney injury in cirrhosis.
Thank you very much, Jose Luis. Good afternoon, everybody. And first of all, I want to thank Jordi, Javier, everybody for the kind invitation. It's really a big honor to be here. So we'll talk about AKI in patients with decompensated cirrhosis, starting with a brief historical overview of the advancement in our understanding of the pathophysiology of AKI in decompensated cirrhosis. And then most of my talk will focus on diagnosis and treatment of AKI, also with some critical comments about new recommendation about the management of AKI in these patients. So let's start with the peripheral arterial vasodilation hypothesis. This started in 1988, suggesting that renal dysfunction in patients with cirrhosis is occurring as a consequence of portal hypertension, which causes a severe splanchnic arterial vasodilation mediated by release of nitric oxide, carbon monoxide. Splanchnic arterial vasodilation causes a reduction of effective circulating volume, stimulating the production of endogenous vasoconstrictor systems such as renin-angiotensin-aldosterone system and norepinephrine. This causes an increase in cardiac output that try to counteract the reduction of effective circulating volume. But in advanced stages of the disease, the cardiac output cannot increase further, and this results in a reduction of renal blood flow that expose the patients to the risk of AKI. And in the most advanced stages, there is also a severe activation of endogenous vasoconstrictor system that causes severe intrarenal vasoconstriction that is the hallmark of hepatorenal syndrome. The peripheral arterial vasodilation hypothesis was revised thereafter when there was evidence that in patients with spontaneous bacterial peritonitis developing hepatorenal syndrome, there is a relative reduction in the cardiac output. And therefore, it was suggested that in advanced stages of the disease, there is also a cardiac dysfunction, namely cirrhotic cardiomyopathy, that causes a relative reduction in cardiac output that contribute to the reduction of effective circulating volume, and therefore to the pathophysiology of AKI and HRS-AKI. Thereafter, in following years, there was a lot of study about the role of pathological bacterial translocation, which was not only involved in the pathogenesis of infection in patients, but also in the pathogenesis of circulatory dysfunction. And indeed, there was evidence that patients showing signs and biomarker of pathological bacterial translocation have an increase in inflammatory cytokines, an increase in indirect biomarkers of nitric oxide production, have lower systemic vascular resistance, and an increased activation of endogenous vasoconstrictor systems. And there was also evidence that inflammation has a role in the reduction of cardiac output. Indeed, you can see that in experimental model of cirrhosis, rats, the cardiac contractility in bile duct ligated rats is reduced. This is associated with an increase in the inducible nitric oxide synthesis expression. But if you administer anti-TNF-alpha antibody or use a mice model knockout for the gene for TNF-alpha, these abnormalities are reverted. And therefore, this and other study led to the systemic inflammation hypothesis, in which one of the mechanisms leading to the splanchnic arterial vasodilation is mediated by gut bacterial translocation, systemic inflammatory response that causes a reduction of cardiac output, and splanchnic arterial vasodilation. And when we talk about systemic inflammation and this pathophysiology of AKI, we are focusing very much on this cardiovascular dysfunction, but we know from other models of inflammatory-induced AKI, such as sepsis-induced AKI, that microvascular dysfunction is just one of the mechanisms of pathophysiology of AKI. Indeed, there are several other mechanisms, such as microvascular dysfunction, immune pathologies with a direct damage caused by immune cells in the kidney, and also mediated by reactive oxygen species and oxidative stress, and also mediated by metabolic changes caused by inflammatory response, namely mitochondrial dysfunction and metabolic reprogramming. And indeed, this may occur even in patients with cirrhosis, because if we look at the individual levels of plasma renin concentration and in patients with renal failure and decompensated cirrhosis, which were enrolled in the canonic study, you can see that there is a group of patients that still develop renal failure without a significant increase in plasma renin activity, while there is nobody that is developing renal failure with normal concentration of inflammatory cytokines such as interleukin-8, but the level of interleukin-6 are the same, and therefore there are alternative mechanisms. So the metabolomic analysis of samples which were collected in the canonic study can try to unveil a little bit the pathophysiology of organ failures, but also renal failures occurring in patients with ACLF. Indeed, the metabolomic analysis of serum samples collected in the canonic study show that there are some specific metabolites that are overexpressed in ACLF. These metabolites are a sort of fingerprint of ACLF that can be resumed with some statistical analysis in one eigen metabolite that is significantly increased in patients with ACLF versus those with just an acute decompensation of cirrhosis, and this eigen metabolites is the same that we observe in patients that have just kidney failure or kidney dysfunction. So if we look at the pathway involved in these metabolites, we can realize and can try to summarize the changes in metabolism that are occurring in patients with renal failure and acute on chronic liver failure as an increase in reactive oxygen species and nitric oxide, causing a mitochondrial dysfunction with an downregulation of oxidative phosphorylation and beta oxidation, with a shift of metabolism to glycolysis and pentose phosphate pathway, which is a mechanism less effective in producing ATP, and that may cause an energetic crisis and therefore metabolic damage in the tubular cells. And therefore, the final update was that systemic inflammation alone in some patients may actually trigger AKI by a direct effects on tubular cells and the kidney by immunopathologies and metabolic reprogramming. And in this pathophysiological background, every event that is causing an increase in systemic inflammation, such as bacterial infections or alcohol-associated hepatitis, or that is causing a worsening of splanchnic arterial vasodilation, such as vasodilators, or that is causing a reduction of effective circulating volume, such as an excess of diuretics, bleeding, large volume paracentesis without albumin, or that is interfering with the mechanism of kidney autoregulation, can actually precipitate AKI, and this is what we currently see in the clinical practice. Now, moving to the diagnosis and treatment of AKI, I just want to remind you that we define acute kidney injury as an acute increase in serum creatinine equal or higher than 0.3 milligram DL within 48 hours, or a relative increase in serum creatinine equal or higher than 50% from baseline within 1 week, And if we are able to monitor urine output, we can also use urine output criteria to define AKI. According to the relative increase in serum creatinine, we can stage AKI in 3 different stages. Stage 1, when the increase is below 2-fold from baseline. Stage 2, when the serum creatinine increase is above 2-fold but less than 3-fold than baseline. And stage 3, when the increase is above 3-fold from the baseline or reach a value above 4 milligram DL. Now, in patients with cirrhosis, it has been suggested that patients with stage 1 AKI can be substratified in 2 groups with a different prognosis. Those that have levels of serum creatinine below 1.5 milligram DL, so-called AKI stage 1A, and those that have serum creatinine equal or higher than 1.5 milligram DL, that is stage 1B. And these patients with stage 1B have a prognosis that is intermediate between those with AKI stage 1A and those with AKI stage 2 or 3. And although some experts criticize this stratification, there are at least 4 studies, including more than 3,000 patients with decompensated cirrhosis, confirming these results. Now, in the initial management of patients with AKI, a key steps is actually to identify and treat precipitating factors, such as infections, excessive diuretic dose, bleeding, use of nephrotoxic drug. And please keep in mind that almost 90% of patients with cirrhosis and AKI actually have precipitating events if you systematically look for it. So the next step is actually the differential diagnosis and the specific AKI treatment that include volume resuscitation and urine analysis. Volume resuscitation is important because if we look at the phenotype of acute kidney injury in patients with cirrhosis, you can realize that more than 1/2 of patients with cirrhosis and AKI have actually hypovolemic AKI. That is volume responsive, while among patients that are not responding to volume expansion, usually the differential diagnosis is between HRS AKI and acute tubular necrosis. Now, in 2015, we suggested an algorithm for the management of AKI in patients with decompensated cirrhosis that later was endorsed with some revision by International Club of Ascites and the EASL guidelines that have 2 different starting boxes, patients with stage 1A and those with stage 1B, 2 or 3. So for patients with stage 1A, it has been suggested to, to identify or remove risk factors, so nephrotoxic drug, vasodilators, to taper or withdraw diuretics, to expand plasma volume in those that are dehydrated or have a sign of volume loss, and to identify and treat infections systematically. And you know that with these measures, you are able to treat more than 80% of patients with stage 1A, because in this study you can see that most of these patients had actually what we call a prerenal AKI, that is volume responsive, and in the miscellaneous group there were mainly patients that have bacterial infection induced AKI or that was associated with the administration of nephrotoxic drug. So if the patients improve, okay, that's fine. If they progress to stage 1B, 2 or 3, for these patients from the beginning is expected a withdrawal of diuretics and plasma volume expansion with albumin with a dose of 1 gram per kilogram of body weight for 2 days. If the patients respond, it's okay. If AKI persists, we should check for criteria of HRS AKI. We will talk in detail later on. If patients do not meet the HRS AKI criteria, usually the diagnosis is acute tubular necrosis, and generally the treatment is supportive treatment, or in patients that require RRT, consider RRT. For patients with HRS AKI, the treatment includes the use of vasoconstrictors and albumin. And some of the criticism to this algorithm is that it's actually expert opinion based. Okay, just the use of vasoconstrictors albumin is supported by randomized controlled trial, But still, keep in mind that if you apply this algorithm in the clinical practice systematically, you are more likely to get a resolution of AKI, and you have a significant reduction in 90-day mortality than when you compare the systematic application of the algorithm versus an historical cohort, with all the limits, of course, of an historical cohort as a comparator. So if you talk with nephrologists in a patient with ascites and edema, they told you, why are you withdrawing diuretics or reducing diuretics, This is what we usually recommend in clinical practice according to our pathophysiology background. And I can tell you that in the global AKI study, this is something that for many of you may be, given for granted, but actually we look at those that were adherent to the International Club of Ascites and Diesel algorithm for the management of diuretics, and those in whom diuretics were tapered or withdrawn according to the algorithm had a significantly higher rate of AKI resolution than those that were not adherent to the treatment. And even after adjusting for several confounders, the adherence to this recommendation was associated with an 18% risk reduction in AKI no resolution. Now, moving to AKI HRS criteria, we have these all criteria that were valid until 1 year ago, where we define HRS-AKI in patients with cirrhosis and ascites that have no improvement in serum creatinine after at least 2 days of diuretic withdrawal and plasma volume expansion with albumin, in absence of shock, use of nephrotoxic drug, and in absence of signs of parenchymal damage defined by proteinuria, microhematuria, and abnormal renal ultrasonography. The last year, these criteria have been updated following a consensus by the Acute Disease Quality Initiative and International Club of Ascites, and there were 2 small but very significant changes. The first one is that was suggested that 24 hours of volume expansion were considered sufficient to evaluate a volume-responsive AKI, and albumin was actually not strictly needed for these patients. And the other change is that you can rule in HRS-AKI if you have no strong evidence of an alternative explanation as the primary cause of AKI. And let me start with the problem, because if you apply the algorithm that I showed you before, so you stop diuretics in patients with stage AKI 1B, 2, or 3, and start plasma volume expansion with albumin, you can see that there are 34% of patients that respond after albumin challenge, but just 61% of them achieve the response within 24 hours. This means that if you apply the new recommendation, almost 40% of patients that are actually volume responsive will be treated with terlipressin and albumin, which is a therapy that, as you will see, have relevant side effects. The other comment is that the recommendation said you should not use systematically albumin in these patients, and therefore after the publication several people asked what I have to do. So what is the alternative? Should we still use albumin? And the issue is that what is the alternative? We know that even patients with compensated cirrhosis have an impaired natriuresis after saline loading. Therefore, if you are administering crystalloids in patients with ascites and edema, this will definitely result in a volume overload. In addition, we have evidence from experimental models of cirrhosis that if you administer albumin before sacrifice in cirrhotic rats, albumin is able to restore cardiac contractility in patients with cirrhotic rats, and these effects are not achieved using synthetic colloids. This is likely related to the non-oncotic properties of albumin, that is, the immune-modulating properties, scavenger properties, and was also proven by the facts that actually, if you treat rats with albumin before the sacrifice, the expression of VINOS that I showed you before is involved in this reduction of cardiac contractility is significantly reduced. The other issue is, should all patients receive 1 gram per kilogram of body weight of albumin, which still this dose is actually expert opinion based? Well, if you look at the data, actually, when you use albumin, there is not very much difference in mortality, but not even in a resolution of AKI, if you use 1 gram per kilogram or as lower doses. Therefore, there is certainly the possibility to try to personalize albumin use in these patients. And we should also keep in mind, and nowadays we are seeing more and more patients with muscle D that usually have diabetes, have some cardiac dysfunction, and using blindly 1 gram per kilogram of body weight albumin could actually result in circulatory overload, and this is really potentially dangerous in patients with AKI, because we know from other fields of medicine that fluid overload may cause an increase in central venous pressure that actually cause kidney congestion and may precipitate HRS-AKI, AKI per se. And indeed, we know from heart failure literature and intensive care unit literature that when central venous pressure rises above 12 millimeters of mercury, there is a progressive and significant decline of glomerular filtration rate. Therefore, what is in the future is to try to personalize the plasma volume expansion with albumin in patients with cirrhosis, perhaps using some non-invasive test, because very few patients have actually a central venous catheter and that you can measure, in which you can measure the central venous pressure. And we have evidence that if you use some simple measures such as the ultrasound of inferior vena cava, you can find that there is a direct correlation between the inferior vena cava diameter at expiration and the central venous pressure, and there is an inverse correlation between the inferior vena cava collapsibility index and the central venous pressure. And in this Indian study, patients that had an inferior vena, 95% of patients that had an inferior vena cava diameter about 2.1 centimeters and the inferior vena cava collapsibility index below 50% had a central venous pressure above 10 millimeters of mercury. That means that this patient does not need further albumin. Okay, this is just one study. We need more study with protocolize the use of these techniques to try to personalize albumin expansion in our patient with decompensated cirrhosis and AKI. Now let me move to the other issue with the new criteria. What is a strong evidence for an alternative explanation as the primary cause of AKI? Because if we do not establish clearly what it is, this will result in a worsening of what is already happening nowadays. So in the global AKI study, we tried to look at the real-life use of terlipressin in patients with cirrhosis and AKI, and what we found is that just 50% of patients with cirrhosis and AKI that are receiving terlipressin actually have HRS. And there are a lot of patients that doesn't need it, such as those with hypovolemia. And there are also several patients that actually have an acute tubular necrosis. And these patients, as you can see, have a very poor response to terlipressin. So you are taking the adverse events, trying to treat the so-called hepatorenal pathophysiology, but this is not evidence-based and may be risky. And with the new criteria, the risk may increase if we do not define what it is a strong evidence of alternative cause of AKI. Well, if we want to look for alternative cause of AKI, we should explore biomarker or tubular damage. You can see in this image some old biomarkers such as urinary sodium concentration of albuminuria, or new biomarkers such as interleukin 18 or NGAL. And indeed, the new biomarker, in particularly NGAL and interleukin 18, showed a very good discrimination ability between patients with HRS-AKI and acute tubular necrosis. Therefore, if you have access to this biomarker, you can really improve your ability to provide an accurate differential diagnosis. The most ready for the prime time is certainly NGAL. We have several studies. These are two studies from the Barcelona group showing that patients with cirrhosis and ATN-AKI, that is intrinsic AKI, have a significantly higher levels of NGAL, confirmed in two studies. This was also confirmed by our group, showing that patients with cirrhosis and ATN-AKI have actually significantly higher level of urinary NGAL with a very accurate discrimination ability. And we and also Barcelona group found that a threshold of 220 nanogram per ml had a very good sensitivity and specificity for ATN-AKI. So to try to summarize what is the difference in the clinical scenario between ATN-AKI and HRS-AKI, the difference is in the type of precipitant, more frequent SBP in HRS-AKI and more frequent shock or nephrotoxic drug in ATN-AKI. There is difference in urinary sodium handling with avid sodium retention in HRS-AKI and increased level of urinary sodium in ATN-AKI. Usually, patients with ATN-AKI have granular cast or granular tubular epithelial cells, and if you have access to new biomarker, you can really increase your capability to discriminate between these two entities. One of the statements in the new recommendation about HRS-AKI was that in this pathophysiological context with several patients also having diabetes, CKD, HRS-AKI may occur even in these patients and may occur even in presence of some small degree of tubular injury. Because, we used to classify our patient with HRS-AKI in 3 different groups: volume responsive, HRS-AKI, and ATN-AKI. But we know that a long-lasting reduction in the volume and renal hypoperfusion may cause ischemic acute tubular necrosis. And this actually may occur even in our patients with HRS-AKI. And we could discriminate some patients with HRS-AKI in 2 different groups. One that have a very mild tubular injury had higher reversibility, while there is another group of patients that have more marked tubular injury and less probability of getting response with vasoconstrictors and albumin. And we actually proven this hypothesis, showing that among patients with HRS-AKI that are treated with acute vasopressor and albumin, terdepressin and albumin, those that have higher level NGAL above the threshold that is the best one to discriminate between HRS-AKI and ATN-AKI have a significantly lower probability or resolution of HRS than those that have less concentration of biomarkers or tubular damage. This has been also externally validated using samples from the PREDICT study and the ACLARA study. In this study, we look at urine samples of patients with HRS-AKI treated with vasoconstrictors and albumin in the ACLARA study and the PREDICT study, and we showed that those that who did not achieve renal recovery had a significantly higher values of NGAL and of albumin, which is another marker of tubular and glomerular damage. What was interesting is that in the same study, we also looked at serum biomarker, serum inflammatory biomarker, and we found that patients who did not achieve renal recovery had a significantly higher level of monocyte chemoattractant protein 1, which in sepsis-induced AKI is a mechanism that is leading the recruitment of leukocytes within the kidney, suggesting that probably some of these patients have some degree of what I call the immunopathology with a direct immune damage to the kidney. Now let me move to vasoconstrictors and albumin, where we have the most body of evidence. We usually use terlipressin to counteract splanchnic arterial vasodilation in combination with albumin to counteract splanchnic, the reduction of a splanchnic of effective circulating volume. Alternative treatment are norepinephrine and albumin, mainly in countries where terlipressin is not available or the costs are not affordable, while a third choice is midodrine plus octreotide, which is actually used only in patients in whom there is a strong contraindication to most powerful vasoconstrictors. So here in these slides, you can see the free randomized controlled trial which compared terlipressin plus albumin versus placebo plus albumin in the treatment of HRS-AKI. And as you can see, it is evident that patients treated with terlipressin had a significantly higher rate of resolution of HRS-AKI than those treated with placebo. The issue is that this study, which are very important, actually used the terlipressin as intravenous boluses, which is not the smartest way to use this drug. Because if you look at this old hemodynamic study exploring the effects of terlipressin on hepatic venous pressure gradient, you can see that after a single bolus of terlipressin, you achieve a rapid reduction of HVPG, but this effect lasts for 3 hours, and at 4 hours there are no differences versus placebo. This means that if you are using terlipressin as intravenous boluses every 4 or every 6 hours, you are not able to achieve an hemodynamic effect that lasts for 24 hours unless you increase the doses of terlipressin. And of course, increasing the doses may increase the risk of side effects, while an alternative option would be the continuous infusion of terlipressin. And actually, we compared these two different administration routes in a randomized controlled trial, showing that both are effective in treating HRS-AKI, no difference in response. However, the doses needed for achieving response in patients treated with continuous intravenous infusion was significantly lower, and this turned in a significant reduction in the incidence of global adverse events and serious adverse events in patients treated with intravenous continuous infusion, and this administration route is what is now recommended in patients with HRS-AKI. Talking about adverse events, terlipressin is very useful but has significant side effects, mainly ischemic one. And among side effects, there was a lot of claim in the last year after the publication of the confirmed trial, which showed a significantly higher incidence of respiratory failure in patients with HRS-AKI randomized to receive terlipressin. And this actually attracted both the concern of FDA and EMA. And the investigators of the confirmed trial tried to identify a group of patients with HRS-AKI with the highest risk of respiratory failure. And what they found is that those that have ACLF grade 3, namely have 3 or more organ failures, were more likely to develop respiratory failure and to die because of respiratory failure following terlipressin treatment. And now we have a black box warning from FDA and also a strong recommendation from the European Medicine Agency suggesting to use with caution or avoid terlipressin in patients with ACLF grade 3. I will say that we already know that in patients with ACLF grade 3, terlipressin is poorly effective. Indeed, you can see in this study that moving from patients with ACLF grade 1 to grade 2 to grade 3, there is a significant reduction in the probability of response to treatment for any value of baseline serum creatinine at which the treatment is observed. And what is most important to me is that even if you get a response in patients with ACLF grade 3, the 90-day mortality is not significantly different when compared to non-responders. There is just a small advantage to 30 days, within 30 days. Therefore, if a patient is a potential transplant candidate, this is an option. Otherwise, it is probably futile and the risks are too much. Now, talking about the alternative treatment, we have some studies mainly from India comparing norepinephrine to terlipressin in the treatment of HRS-AKI. Some of these studies showed similar efficacy versus terlipressin. Some more recent study in sicker patients meeting ACLF criteria called APASL. In these patients, terlipressin seems to be slightly more effective than norepinephrine in inducing HRS reversal. Still, terlipressin can be used in the ward. Norepinephrine usually should be administered under continuous monitoring. Anyway, it is an alternative. Midodrine and octreotide, as I told you before, this is a third choice. This is poorly effective when compared to terlipressin and albumin, and usually is referred to patients with absolute contraindication to terlipressin, such as patients that have ischemic heart disease. Now, if we look, at the outcome of responders to vasoconstrictors and albumin, you can see that actually responders have a significantly improvement in the probability of survival than non-responder. However, if you compare these results with what is achieved with liver transplantation, there is no story. So liver transplantation is the best treatment of patients with HRS-AKI, and therefore all patients with HRS-AKI that are potentially transplant candidates should be rapidly evaluated for liver transplantation. However, what occurs in clinical practice is that these two treatments are not mutually exclusive. Usually, patients with HRS-AKI that are transplant candidates are treated with vasoconstrictors and albumin before liver transplantation, and achieving a response to terlipressin and albumin is associated with significant improvement in post-transplant outcome, namely a significant reduction in the incidence of chronic kidney disease after liver transplantation when compared to non-responders. And indeed, even after adjusting for several confounders, non-responder had a significantly higher incidence of CKD. And this reduced incidence of CKD is not negligible, because you know that in liver transplant patients, heavy reduction of glomerular filtration rate below 60 ml is that is the threshold that we use to define CKD, is associated with an exponential increase in the risk of post-transplant mortality. So what about patients that are not responding to vasoconstrictors and albumin? Usually, in these patients, we likely meet the criteria for renal replacement therapy. And the clinical decision about renal replacement therapy is usually hard. If these patients has the perspective of liver transplantation, still have an acceptable good outcome with 6 months mortality of about 40%. However, if liver transplant is not an option because the patient is not listed to liver transplantation and it's not a potential candidate, mortality rate raised to 80%. That means that for most of these patients, renal replacement therapy is likely futile and should be decided case by case. So in conclusion, dear colleagues, systemic inflammation, splanchnic arterial vasodilation, and cardiocirculatory dysfunction plays a key role in the pathogenesis of AKI in decompensated cirrhosis. My suggestion is that until new data become available, it is reasonable to use EASL ICA algorithm for the management of AKI in decompensated cirrhosis. In centers where NGAL is available, it can be used to improve the differential diagnosis between HRS-AKI and ATN-AKI, and also as a prognostic biomarker to predict probability of response with terlipressin and albumin. Terlipressin and albumin is the first-line treatment for patients that meet criteria of HRS-AKI, but please be cautious with patients with ACLF grade 3 that are not potential liver transplant candidates. And finally, never forget that liver transplantation is the best treatment for HRS-AKI. This is my last slide. I want to thank all my group and my team. And please apologize if I refer to very old studies, but you know that nowadays we have some crises with some very important old studies, and sometimes to have a persistence of memory is very important. Thank you very much. Actually, patients that have sarcopenia have lower serum creatinine, but this is usually more important for evaluating the baseline glomerular filtration rate, because you know, with applying this new AKI criteria that in which a very small increase in serum creatinine on 0.3 milligram DL in 48 hours is sufficient to identify AKI. So the problem is mainly for the assessment of glomerular filtration rate in stable patients than in those with AKI. Well, this is very unlikely to me, because for developing HRS-AKI, you should have a really severe sodium and water retention that usually precede the occurrence of HRS-AKI. So this is really rare. If you have just perihepatic ascites, it is very unlikely that you may have HRS-AKI. Actually, the issue of MASLD is relevant. Most of these patients may have an underlying chronic kidney disease. Usually, chronic kidney disease occurring in these patients that have hypertension or diabetes is mainly glomerular damage. So you will find albuminuria and proteinuria, but usually the tubule are not that damaged. So we will look in detail to the data, but what I expect is that the biomarker of tubular damage, when we are talking about acute tubular necrosis, will not change very much. What I agree with you, that is probably the use of proteinuria for assessing, you know, a lack of parenchymal kidney damage in this patient will not be useful. You may have patients with HRS-AKI that have, you know, mild proteinuria because of underlying chronic kidney disease, diabetic kidney disease. This is a relevant issue. So also one of the reasons why our understanding of the pathophysiology is limited, because we have not adequate experimental models and we are not performing biopsy, because when biopsy was performed, it was actually associated with significant side effects, hemorrhage. So I would consider biopsy I will almost never consider biopsy unless you have, you know, a patients that have a very severe AKI with mild ascites, as the one he was discussing before, in which you may have, you know, an interstitial nephritis or another nephritis for this specific patient, yes. But for a patient with dense ascites, decompensated cirrhosis, ACLF, this is likely too risky. Yes, actually, in bile duct ligated models, that usually is a very severe inflammatory models. There is the evidence of overexpression of toll-like receptors 4 in the kidney of these patients, and actually this is also the background for the use in the future of toll-like receptor 4 inhibitors such as TAC, that is under investigation in the A-Tango studies. But you know, the bile duct ligated models is really a specific model where you for sure have also a cholemic nephropathy, because you have a very huge increase in bilirubin bile acids that usually you do not achieve in patients in the patient with cirrhosis that we see. Definitely, we already have evidence that those patients that have developed AKI and that have AKI recovery have a significant increase in the risk of chronic kidney disease thereafter. Therefore, it is likely that there is after any episodes of AKI, there is some reduction in what we call the renal reserve. Okay, so and therefore, for sure, they are associated with a significant increase in the incidence of chronic kidney disease. Was the classical patients that we were seeing in patients with HCV or HBV viral infection, or with young patients with alcohol-related liver disease. Nowadays, we are seeing more and more the first type of patients that you mentioned that have perhaps an underlying cardiac disease. But if you see a patients that have signs of congestive heart failure, and as you mentioned, the increase in the jugular vein, I mean, that is a strong sign of increased central venous pressure. That patient likely doesn't need a plasma volume expansion. If you do a point of care ultrasound, you will find that signs, and this patient doesn't need further albumin expansion, and even the use of terlipressin that actually decrease cardiac output may be dangerous. And therefore, this is something that we should explore better in the future. But this is a patient in which you may consider to still use diuretics. I mean, this is what I do in clinical practice. We have very few evidence about that, but we are seeing more and more these patients, and we will study more and more these patients to generate evidence and to make recommendations that are more evidence-based. Yeah. I mean, so these usually when these patients they are translated in the ICU, and they need continuous renal replacement therapy because none of them will tolerate intermittent dialysis. And what I can say is that if there is no transplant perspectives, in my experience, most of these patients will die. Well, what we have is ENGAL. So because this is available in our lab, we can ask for it. We are allowed, and I don't know about. We never did a cost-effective analysis, but it's what I use in clinical practice usually for more as a predictive factors. Both diagnostic and predictive factors. So what I can say, for example, you have patients that meet HRS-AKI criteria but have levels of urinary ENGAL that is 1,500. In these patients, I reconsider the clinical diagnosis of HRS-AKI. This is probably ATN, and I start discussing with the nephrologist to plan for renal replacement therapy in case this is a candidate, because it is likely that he will not respond. Definitely, in all patients we use continuous intravenous infusion, and I can tell you that in most part of the world is the preferred type. In the global AKI study, we look at the pattern of use, and in 80% of cases, people worldwide is using it as continuous intravenous infusion. So, my opinion is that in the standard patients with HRS-AKI that we are seeing before is the second mechanism. The problem is that in patients with muscle D that perhaps have a long-lasting story of hypertension, or after developing, normalization of blood pressure because the compensated cirrhosis cure arterial hypertension. In that case, probably there is actually a structural damage in the heart, but still, in the future we will see more and more these patients, and in the field in the future we should try to distinguish between two kind of patients that will also turn out in different clinical decision about the management. Yeah, definitely. So for patients with ascites that are recovering from HRS-AKI and still have ascites, you may consider it to prevent recurrence. Regarding treatment, we should ask to Christina, that is performing a randomized controlled trial comparing vasopressor and albumin versus TIPS, because ideally, you are reducing acutely portal pressure. That is, the first step in the pathophysiology of the syndrome. Whether in the acute phase this may actually succeed should be proven, but Christina will answer in the next years.